So lactation this is where we stop. Of course, so I've told us the what happens to lactation. The major hormone that is responsible for production of milk is prolactin. So during the course of pregnancy, prolactin is being produced due to the influence of estrogen and progesterone on the anterior pituitary glands. They stimulate production of prolactin, but they inhibit the action of prolactin on the breast. So there is no production of milk eventually. So no lactation. So until the placenta is separated from the fetus and there's a drop in the estrogen and progesterone level, that's when prolactin can now act on the breast to initiate milk production. So remember the sucking reflex that once the baby starts sucking, it brings about milk production as well as ejection due to increased production of prolactin and oxytocin. Prolactin at the same time, in addition to stimulating breast milk production, it also inhibits GnRH. So someone that is pregnant, someone that just delivered a baby and the person is providing breast milk exclusively to the fetus, the level of prolactin rises. That prolactin inhibits GnRH from the hypothalamus, and of course that will also inhibit production of LH and FSH, and will inhibit the menstrual cycle of a thing. So in the ovulation is prevented, and the other aspect of the menstrual cycle. So you call that phenomenon lactational amenorrhea. So the person may not even menstruate because of the inhibitory action of prolactin on GnRH. So a mother that lactates very well, you don't expect that person to resume menses early compared to the one that is not lactating well. So oxytocin is also another hormone that is being produced when the baby starts sucking, and what it does is to achieve the process of milk secretion or leg down. And it's also an hormone that is implicated in stimulating uterine contraction alongside with some prostaglandin. So prostaglandin, oxytocin are involved in stimulating uterine contraction. So what are the components of breast milk? Breast milk is actually ideal for infants that are less than 6 months. You want to give them breast milk because it's very rich in proteins, particularly immunoglobulins. So it contains immunoglobulins, and immunoglobulins that is contained in breast milk is actually IgA. IgG also comes from the mother, crosses the placenta directly into the baby. It doesn't have to go through breast milk. But the one that is majorly from breast milk is IgA. We should not forget. IgA also contains white blood cells that help the fetus to fight infections, like macrophages, lymphocytes. So if you are looking at the component of breast milk, we are looking at proteins, we are looking at some fats, but majorly proteins, white blood cells, macrophages, lymphocytes, proteins like immunoglobulins, and in form of IgA. Those are the things that can help the fetus fight infection. Then it has been shown that breast milk can help to reduce the occurrence of obesity in the fetus, in the child, development of diabetes, allergies, and asthma. All these things are just due to studies. It's not as if we have a pathophysiologic mechanism that we can be using to explain how breast milk can do this. So just one of those things that we need to know, that there's low incidence of diabetes, obesity, asthma, and other allergic diseases in people that are well breastfed during their childhood. But there are some um, substances or nutritional substances that are not well present in breast milk. This includes vitamin D and iron. Some say calcium too. So you need to supplement um, the child that is exclusively breastfed without any other things, just pure breast milk that the person is taking, with a very good vitamin D and iron supplement. So breastfeeding also helps to initiate bonding with the mother, and people that breastfeed regularly, they have been shown to have reduced incidence of ovarian and breast cancer. So breastfeeding reduces incidence of ovarian cancer, breast cancer, reduce incidence of diabetes, obesity. Those ones go together. Asthma and allergy, they go together. It contains protein in form of immunoglobulin, particularly IgA. So IgA, because it's a mucosal immunoglobulin, so it helps to protect against mucosal infections like respiratory tract infections, like gastrointestinal infection. So there's little incidence of diarrhea there's little incidence of respiratory tract infection in a baby that is well breastfed. Then we know that what else do I want to say? That okay, some nutrients are not abundant in breast milk, vitamin D particularly, and vitamin K and iron. Sorry, vitamin D and iron. So you want to supply um those ones to the baby. Yeah. So let's go to menopause. So menopause is just diagnosed as amenorrhea of 12 months. So someone that has amenorrhea for 12 months within the age of about 45 to 55 years, you can say that this person is menopausal. The person is going to present with some symptoms too. An individual might not have all, but the commonest is hot flashes. So they just feel this excessive body heat for no reason. So hot flashes, they have low libido, so they are not willing to have sex. They have low libido. The vagina is atrophied because of the fact that they have low level of estrogen. Low level of estrogen, they are predisposed to osteoporosis because osteoporosis is one of the things that stimulate the osteoblast to form more bone. So and also inhibit the action of the osteoclast. If you can remember from our musculoskeletal lecture. Please, Dr. Oluwatobi, guys, please hope I'm not talking too fast.
No, we are following you.
It's
We're
fine,
on
we're
it.
following.
Okay, so there is hot flashes, which is the commonest. There's low libido. There's atrophy of the vagina. They are predisposed to some other symptoms, especially due to the estrogen depletion. Majority of them are actually explained by the estrogen depletion that they have. So the other symptoms include osteoporosis because of reduced stimulation of the osteoblast and unopposed activity of the osteoclast. And of course, estrogen, like I've said earlier too, that estrogen helps to increase the level of HDL and reduce the level of LDL. So that balance, changes. So that means you have more of LDL and less of HDL in someone that is postmenopausal or yeah, postmenopausal. So they have high LDL and low HDL, which will predispose them to coronary arterial disease. And they also have issues with sleep, so they can experience sleep disturbances. So the code is the acronym is AVOC if you want to use it. AVOC, hot
Sorry,
flashes.
please
Yes, Dr.
repeat
Lua.
the osteoporosis on, please.
So osteoporosis due to reduce estrogen to stimulate the osteoblast and reduce estrogen to inhibit the osteoclast. Estrogen normally stimulates osteoblast and inhibit osteoclast. So if there is no estrogen again, that means you have your osteoblast not functioning and you have unopposed action of your osteoclast, destroying the bone, causing osteoporosis. So how does it come about? I've told us that with time, all the oocytes becomes used up. All the oocyte becomes depleted. So between 45 to 55 years, but average of 51 years, oocyte will have been depleted. And we know that the oocyte contains the granulosa cells that helps to secrete estrogen. So the estrogen level is going to be low. The little estrogen that will be present will be that one that is coming from the adipose tissue. Because the three things that secrete estrogen, if you can remember, the adipose that secrete estrone, the placenta that secrete estriol, and the ovaries that secrete estradiol. So we'll only be left with the estradiol and adipose in someone that is not pregnant. So with time, the one that is coming from the ovaries will reduce because of the depletion of the ovarian follicles. So it will only remain the adipose that is secreting estrone, which is not as potent as estradiol. So, but it's also important for us to know that people that smokes actually experience menopause earlier than normal people. So they might experience their own before the usual time. And one of the features of menopause is that 4 to 5 years before menopause actually sets in, we experience some irregularities of the cycle. So there will be some, abnormality in the menstrual cycle before um, menopause. So if you ask a woman that starts experiencing the symptoms of menopause now, if you ask the woman like 4 or 5 years ago, were you experiencing abnormality in your menstrual cycle, majority of them will, confirm that they actually experienced abnormalities in their uterine cycle. So The only, like I've mentioned, the only source of estrogen after menopause is estrone, which is the one that is coming from our adipose tissue from peripheral conversion of androgens to um estrone. So the anybody that have this uh okay, so that's that. So majority of the androgens are just being converted to estrone in menopausal people. And one thing I want us to remember is that some people can get confused. They might say that, okay, this woman that is menopausal, is it that this woman actually has maybe a secondary amenorrhea? Although if you ask the age and you're able to collect the history of these symptoms, you should nail your diagnosis of menopause. But some people might want to go further to do some testing. So the lab picture that is typical of menopause is high FSH, because estrogen level reduces and the inhibitory effect of estrogen, particularly on FSH, reduces. So there's abundant secretion of FSH more than LH. So there's a double increase in FSH more than that of the LH. So FSH level is very, very high in people that are postmenopausal. You know, in most people that are amenorrheic due to other causes, you can actually observe that the FSH will be low. And that low FSH is what is causing reduction in estrogen, because there's nothing to stimulate the follicles to develop the follicles so that they can release estrogen. Maybe someone that has thyroid issues. Thyroid issues will eventually affect secretion of GnRH. GnRH level will be low, FSH will be low, estrogen will be low. They will experience amenorrhea. What's it called? What else can affect uh so many things, so many things. If the person is maybe has used chemotherapy and there's damage to the ovaries or something, estrogen level 2 will be reduced, FSH2 will drop. But menopause, you know, is specific, the specific marker that you see in menopause is elevated FSH. FSH level is high because of the unopposed action of estrogen, which is the primary problem. Estrogen is the primary problem. Estrogen reduction is primary problem. So estrogen level is low, and there's no inhibitory effect of estrogen on FSH and LH again. So FSH is actually higher than LH, and of course, the upstream one, which is GnRH, is also elevated. So those are the three features that you see. So once you see someone, you want to confirm your menopause, you assay for the FSH, LH, and GnRH. The three of them will be elevated in someone that has menopause. So I've talked about the symptoms of menopause. Then it's also important for us to know that if someone experiences symptoms of menopause before the age of 40, that is not physiologic. That is actually called primary ovarian failure, or premature ovarian failure or primary ovarian insufficiency. This condition can occur in people that have received chemotherapy or radiation therapy that have destroyed the ovaries, because they are part of the labile cells. That the germ cells of the ovaries are labile cells. They regenerate continuously at every time. You know, they have little time. They don't even go to G naught phase. They don't rest. They are continuously dividing through mitosis. So through the process of mitosis, meiosis, and all those things. So they are continuously dividing, so they don't rest. So they are very, very sensitive to chemotherapy and radiation damage. Another condition that can cause primary ovarian failure is Fragile X syndrome. The Fragile X syndrome, especially if the repeat is less than 200. We'll get to it. We'll understand it better. So just know it that Fragile X syndrome can cause premature ovarian failure. And we know that Fragile X syndrome is one of the conditions that is associated with trinucleotide repeat, CGG. CGG. We should not forget that. So it can be associated with premature ovarian syndrome. So let me move. So guys, I'll just try to explain androgens. I will call it a day because I need to prepare for the class in the evening. So androgens, we have three androgens: testosterone, dihydrotestosterone, and androstenedione. Although we also have dihydroepiandrosterone too. There are actually four. Dihydroepiandrosterone is also the fourth one. So where do they come from? Androstenedione is produced from the adrenal glands. We have peripheral conversion of um, androstenedione to DHT and testosterone in the tissues like the testes. We can also produce it in the adrenal glands too. So yeah, so so what's the function of testosterone? What's the function of DHT? They have different functions. Although let me say they complement each other. So, like we know from our knowledge of embryology, that the differentiation of the mesonephric duct into epididymis, vas deferens, seminal vesicles, except the prostate, is driven by testosterone. So testosterone actually acts on the mesonephric duct, causing it to differentiate into the seed, the seminal vesicles, epididymis, vas deferens, and the ejaculatory duct. At the same time, testosterone is responsible for the growth sprout. That um, people, that males at puberty experience. So the penile enlargement that they experience, enlargement of the seminal vesicles, production of sperm that happens at puberty, building of the muscle mass, increase in the amount of red blood cells, is associated with testosterone. That is why anybody that is doping or using exogenous testosterone can have erythrocytosis, because testosterone is involved in production of red blood cells. They can have an increase in the muscle mass, which is fat free, because it's very, very important in muscle development. Of course, we know this sperm production, androgens in form of testosterone is important for sperm production. That is why our Sertoli cells will always release androgen binding protein to concentrate the sperm, the androgens within the seminiferous tubules. It's also involved in growth sprouts, in terms of the penile enlargement and seminal vesicle enlargement during the process of, puberty. It allows for deepening of the voice, so that's why males generally have deepened voice compared to the females. And it also helps in the closing of the epiphyseal plate, although that function is usually due to conversion of testosterone to estrogen. It's estrogen that actually does this closing of the epiphyseal plate. And when that happens, there's cessation of growth. So when someone, gets to puberty, and it gets to a time for the epiphyseal plate to fuse, testosterone that is abundant during that period is being converted to estrogen that actually causes fusion of the epiphyseal plate and limit linear bone growth. It's also important in driving the libido in males, while estrogen is the one that drives the libido in females. So, what are the functions of DHE? We already know it's a very early hormone. It's the one that helps to develop the external genitalia in the early phase. But once puberty is reached, testosterone takes over. So, the variation of the external genitalia in early phase, particularly the penis, the scrotum, and the prostate, is driven by DHT. Also, later part, prostate growth is also all influenced by DHT. DHT is involved in balding. You need to remember this. It comes out a lot. Balding, DHT, balding. I've seen it in a question before. So, DHT drives balding. DHT drives um, male pattern, you know, baldness. And it also helps to, increase um, um, sebaceous gland secretion. So it can be responsible for the phenomenon of acne formation. So DHT, early differentiation of the external genitalia, it helps to develop the prostate at the later stage, helps to develop secretion of the sebaceous gland, helps to, you know, drive the balding pattern in males. Okay, so yeah, so of course we know the hormone that is involved in production of our DHT, that is our 5-alpha reductase. So 5-alpha reductase acts on testosterone, converting it to DHT, particularly in the testes, and that hormone, or that enzyme rather, can be inhibited by finasteride. So you want to um, inhibit production of DHT from testosterone. Now, this phenomenon is important in treating prostatic cancer. So anybody that has prostatic CA, because we've said it here that the both the early and the late development of the prostate is under the influence of DHT. So it makes sense to just give the person finasteride, and you don't bother about the testosterone that is accumulating, because testosterone has little or no effect on prostate development. It is the DHT. Why not just inhibit that DHT and prevent feeding that tumor with, the growth stimulus? Give the person finasteride, and you can achieve control of the tumor growth in the prostate. Um, so majority of the androgens are also, being converted from estrogen by the aromatase enzyme, which occurs in the adipose tissue and the testes. adipose tissue and testes, aromatic enzyme works there that helps to generate our androgens. So what is the consequence of individuals that are using anabolic steroid that is high in androgens, particularly testosterone? But one, we've talked about the fact that it's involving muscle development, so there's increased muscle strength, and in these people there's mobilization of fat. So fat metabolism is high, so they have fat-free muscle mass. So the muscle is entirely devoid of fat. They have little fat and more muscle, and of course this is going to improve their performance because they are full of muscles. It's been shown that people that use anabolic steroid that is high in testosterone show some aggressive changes, because we know that testosterone can be converted to DHT that can trigger increased sebaceous gland activity. So there is high chance of them developing acne. It also drives gynecomastia because of the fact that the androgens can be converted to estrogen. So the testosterone that they are taking will be converted to estrogen that will act on the breast, and you just see them developing gynecomastia. Then, because of the fact that we know that testosterone can act on the red blood cell to produce more red blood cells, so the high chance of them developing erythrocytosis. When there is erythrocytosis, there's polycythemia, there's high viscosity of the blood, which predispose to thromboembolism. They have small testes because the high testosterone that you are giving will naturally go and inhibit FSH, LH, and GnRH. So they are low. So they cannot stimulate natural production of testosterone from the testes. Of course, the testosterone that you are using exogenously cannot keep up to the metabolic demands of the body naturally. So that means that eventually the testis is going to appear small because of little testosterone that is present. Because of course you need um, testosterone to keep the testes in form. Process of maintaining the cells that are there, the Sertoli cells, the seminiferous tubules, the spermatogonial, and all the cells. At the end of the day, if there's less testosterone support, the testes they shrink in size. So just like the same thing I've explained here, so decrease intratesticular testosterone decreases testicular size, there's less sperm production, and the person presents with azoospermia at the end of the day. In females, if they are taking testosterone, a female that's taking testosterone, we actually experience the process of virilization. So virilization means differentiation of the external genitalia of a particular individual, specifically females, into the male pattern. That's the meaning of virilization. We encounter this word a lot when we are talking about congenital adrenal hyperplasia. So because of the high testosterone, um, we are going to have a lot of male changes, main changes in the female. So one of them is hirsutism, hair production. That's why people with PCOS, they have high androgens too. They experience hirsutism, increased production of hair. Acne because of the sebaceous gland activity, increased conversion of the testosterone effect on the breast. Brings about breast atrophy because uh estrogen is what is involved in breast stimulation. So if you are now giving them a lot of testosterone, it causes atrophy of the breast. So it brings about the main pattern baldness due to the influence of DHT in them. So we might not actually need to memorize all these things. We should just be able to explain why they exist so that when we see it in questions, we'll be able to know that, okay, this is familiar. This should happen when someone is using androgens.
So why did you say acne happen?
So acne is due to the fact that DHT level rises, and DHT can stimulate the sebaceous gland to secrete sebaceous, secretion that is oily. So that's why they can have acne. Mm, They can have acne. So the very, very key features of virilization, hirsutism, acne, those two ones, they are very, very important. Once you see hirsutism and acne in a question, you know that they are talking about increased testosterone secretion. You cannot miss it. Testosterone secretion from anything. It can be from anything. Maybe the person is using um exogenous steroid, or the person is having polycystic ovarian syndrome. We'll get there. They also have high androgens in them, and they experience hirsutism and acne. Then of course they're going to have breast atrophy as well as the male pattern baldness in females. So that is that.
But only sorry, something is confusing me. How come they wrote decrease in testicular testosterone?
Yes, I explained it. I said When you are using testosterone exogenously, it's going to inhibit the hypothalamus, So GnRH level drops, FSH drops, LH drops. So they cannot stimulate the testes to produce testosterone normally.
Okay.
And you know that testosterone that you are taking cannot meet the normal metabolic demands of testosterone in the testes. It can, because you cannot take, you know, what the body actually needs. Do you understand, Doctor?
Yes, yes. So is it the
So
decrease in testosterone that is causing all this hirsutism, acne, and all that?
exactly. So
The decrease, Abby?
no. Decrease testosterone is what is causing the reduced sperm count, not the acne.
Okay, okay, okay.
Acne is the one that is
Okay.
happening when a female is taking it.
Okay, okay, I
But
get.
in a male, due to suppression of the hypothalamic axis, there's eventual reduction in testicular testosterone, and testicular size reduces sperm count. It's just like picturing someone that uses exogenous glucocorticoid. What actually happens? So you can have Addison disease from there because of the fact that the exogenous one you are taking will have suppressed release of
The hypothalamus.
the hypothalamus secreting ACTH and CRH. So once you withdraw from that exogenous one, the person is finished. So the person can, enter Addison crisis straight up and start manifesting with Addison. Do you understand? So the same principle is also working here.
Yeah.
So that is it. That is it. So we'll continue from here next time by God's grace. So I just needed to expose you guys to some questions. So